So we'll get started. It's really a pleasure and privilege for us to have Kevin Croce here. Kevin's, very well known in the CTO and complex PCI space. He's the director of the CTO program at Brigham. We know you do a lot of work with patients who've had stent failure. And this was really a requested topic from our fellows, throughout the year. So, we're really looking forward to hearing from you and then having a discussion afterwards.
Great. Well, thanks for the invite. I got a ton of friends there. It's an honor to be part of this. It's kind of fun. The timing is good, Yusuf, because we spent a lot of time, myself and Evan Schlafmitz and Angela McInerney, developing kind of a comprehensive approach to stent failure that we rolled out at Optima London about 4 or 5 months ago. And so a lot of the content I have for this slide deck is from that. And I have to give credit to the optimal team and Vascular Perspectives, because they're really good at developing medical education content and sort of illustrating slides. And so a lot of the slides, which are much prettier than my stick figure PowerPoint skills to put together on my own, came together through a collaboration with them that we did for Optima. And so it's been cool because we've been thinking a lot about how to consolidate a lot of disparate topics within stent failure. So I sort of did my best to pare down the 3 or 4 decks we made for Evan and me for the program into something that's digestible. So if we get a little long on time, I'll just skip the case examples at the end, because I think you guys are pretty facile with this. But it's meant to be a little bit of an overview and then a kind of comprehensive algorithm that we built that I'll go through in some detail. So without further ado, what's the scope of the problem for stent failure? It's kind of fun because you guys have a brachytherapy program and see a lot of these referrals. So I know that the team there gets the importance of this in interventional cardiology. And it's a bit of an orphan topic, unfortunately. As we know, in-stent restenosis is common. Out of all PCI procedures in the NCDR, currently, somewhere between 10 to 12%, depending upon which reference you look at, of all PCI procedures in the United States are to treat in-stent restenosis. So this is an important problem. This equates to about 80,000 cases per year in the United States. This is just general DES data. I think, we put these things in, but it's often lost on our fellows in particular that 1 in 7 patients that we stent are going to be back in 5 years with a stent-related event. And this is across all stent platforms, 2nd generation, 3rd generation, and this really ascends to a high number as we start to treat patients who have complex coronary disease, where the risk of stent failure is actually higher than just general populations. It's well described that ISR has a poor prognosis. Without question, we know that patients do poorly. TLR of a prior to stent is an independent risk factor for long-term mortality, shown in this study. And additionally, we know that TLR and stent failure really have worse outcomes for patients. Successful ISR PCI is associated with a 15% chance of coming back in 12 months and a 20% chance of coming back in 24 months. And so when we treat patients with stent failure, the stakes are really high because we need to do a good job, because we know they're the most stent failure again, or second stent failure prone population of people that we treat. So it's important to think about how to do an optimal job. And we'll think a little bit about that with regard to the algorithm we developed for this. This is a study from Bobby Ye and Hector Tamez, which again shows MACE is worse for ISR patients undergoing PCI. The ISR group does much, much worse. And a lot of this is driven by target lesion revascularization, as we know. And so thinking about how to prevent stent failure, this is not an intravascular imaging talk, but you really can't think about why stents fail without kind of giving nod to the fact that we've got good tools that can lessen the chances of stent failure. These are the 2 studies, randomized studies in the current space, our IVUS XPL and Ultimate, which we cut down stent failure in half. And we do that by the fact that we know what causes stents to not last or not be durable. Small stents with small minimal luminal areas do much worse than when we make stents big. And if we land in distal or proximal reference narrowing in disease, we know that stents are prone to fail. And we obviously can't leave distal edge dissections because these are pretty noxious from a stent durability standpoint. So as we think about how to avoid stent failure, we get clear data of what matters. Oh, was there a question?
No, Kevin, I was just commenting that at least for myself, we always, I think, view malapposition as the primary role for imaging. And in fact, here, there are many other things that maybe you want to be looking at before being like, the stent's well opposed, the stent's not well opposed.
Yeah, no, totally. And when I was a fellow, as probably you were, it was back in the era when there were all those New England Journal papers that DES were killing people, and we really chased malapposition. It's been clearly shown that a malopposed stent, if the expansion is excellent, actually is not a hazard for MACE. And so we've pivoted to think about landing zones and sizing and percent expansion, and a lot less about malapposition. Malapposition is a hazard, probably honestly, only when it's proximal. And that's because if you or your partner have to treat the patient again, you're likely to get under it. But well expanded stents, if there's a little bit of malapposition, is typically not something that's dangerous. And so that's the nice part about what we do, is as we get data, we can redefine what our approach to things are. And it's changed certainly in my career as an interventionalist. That's a great point. And so, if you think about why stents fail, this is data from the CRF group. It just simply shows early stent failure and late stent failure. At least half of it is attributable to underexpansion in some part, with area less than 4 being, 50% of early stent failures and about 45% of late stent failures. And so, we know that small sizing is associated both with acute problems, and if you just look back retrospectively at failed stents, we see that smaller ones fare poorly in terms of their durability. And so, this is a question which Bill Lombardi asked at a CTO meeting we were at a couple of years ago, and it really resonated with me. We always talk about the newest generation of Onyx and Xience and Synergy, and holy grail is to try to reduce TLF in stent platforms. But if you had a stent that would do that, you'd obviously use it. But instead, we actually have IVUS and OCT, which have been shown in randomized studies to do the same thing. This is IVUS XPL Ultimate. Another trial was presented just a couple of weeks ago that showed an OCT and IVUS again reduce the hazard of stent failure in MACE. And so we've got good tools outside of new stents that cut stent failure by 50%. And so the fact that these tools aren't adopted more than probably 18% of US PCIs on the most glass half full data that we look at is somewhat maddening to me. And I know that you guys have adopted this as a large part of your practice because you believe also it makes a big difference. Image-guided PCI, I won't belabor this, is easy now. With a collaborative, with a whole bunch of colleagues, we developed MLD Max, which is just a paint-by-number approach to a prescriptive strategy for using IVUS or OCT to guide stenting. We look to see that we know if there's calcium there with morphology. We try to land normal to normal when possible, and we make sure we know the diameter of the stent based on intravascular imaging. These are all detected better with IVUS or OCT than the angiogram can tell us. And that's why imaging matters in terms of durability. It's related to what we do to define landing zones and morphology and sizing. And on the back end, we get rid of the things that have been shown to be MACE predictors, which are dissections and expansion. And we look at apposition to the extent that it can affect reintervention. We looked at this in Light Lab, which is a paper that Brian was the lead author on from our group that was published a few months ago. And if you use MLD Max to guide your case, it changes what you do across case planning and stent optimization 88% of the time. And everything in red is how the OCT changed what you would have done based on your initial thought when you looked at the angiogram, and things that are important, like how you prep the vessel, what stent diameter you choose, and addressing underexpansion. And so the mechanism of how intravascular imaging makes stents more durable is pretty clear. And when we use the imaging, we change our practice to be able to address things that we know are related to how stents fail. So, there's a lot of barriers to intravascular imaging. One of them is training. That's why we developed MLD Max, is to make it easy and prescriptive. And the other is potential time. You've got 9 cases on your schedule for the day. Your kids have soccer practice. I understand that people don't want to, launch into a PhD dissertation of intravascular imaging in every case. So we looked at this in Light Lab. And if you use MLD Max for a pre-PCI OCT and a post-PCI OCT, it only adds 9 minutes to the case. And in Disrupt CAD3, which had an OCT sub-study of 100 patients, it didn't add any time to the case. And so with modern image-guided strategies, how to do this, it's quick, it's meaningful, and it doesn't slow you down very much. And we've got some other workflow kernels of data coming out of Light Lab, which have recently been published that we won't have a chance to go over today. And so the summary for this is it matters for outcomes. It's easy to do, and it doesn't take very long with a little bit of practice. We estimate that after about 20 training cases of MLD Max, doctors can get this done in a very, very quick and efficient way. So any thoughts or comments on that before we move into the ISR portion of it?
No, I think, we're using a lot of imaging here. We actually have Daniel Chamier, who sat next to me, who's an interventional cardiologist from Brazil, and he was the PI on the eyesight trial.
Yeah.
And he's here to, help us establish an imaging core lab. And a big part of that is in, trying to, simplify workflows for imaging in terms of interpretation, and then hopefully moving towards, more unified way of, applying the imaging findings.
Yeah, Daniel and I have a lot of common friends in Brazil, and we had a chance to hang out. It was probably about 4 months ago, right now, Daniel?
Yeah, I think so.
We had a lovely time in Boston together, and I'm quite envious, Yusuf. I wish we had Daniel for our program. You guys are really lucky to have him there.
He's
Be able to do great things.
It's a huge boost for us.
Yeah, I think, in the fact that, you and the team and Alexander have been able to leverage someone like Daniel there, I think is a real testament to, a desire to really embrace the data and do well on this. So cheers. I think it's a cool initiative, certainly. So, thinking about when stents fail, we have ideas of why they fail, but invariably some part of this is probably not preventable. And so with intravascular imaging, we really believe it's requisite for treating in-stent restenosis. And Daniel and I actually had conversations about this when we were together a few months ago. And so this is sort of a cartoon we put together to frame the concept of stent failure. The heart's kind of like a tree. There's a segment of a heart here that's shown in brown, which isn't getting enough blood flow from a failed stent. But the idea is, insufficient blood flow from a stent that's not working well doesn't tell the whole story. And we really talk about getting to the root cause of stent failure with intravascular imaging, because an angiogram in no way tells you enough what's going on with the failed stent to allow you to optimally treat it. And so the concept here is that, you need to dig down to the roots to see why the stent is no longer open, because there's varying mechanisms to that which are not well elucidated by angiography. The mechanisms of ISR not detected by angiography are multiple. This is just meant to be, I think, for our fellows and people new in this space, a gallery of images so you can start to train your eye to what you're seeing in stent failure cases. For the seasoned interventional attendings here, I'm going to go through this relatively quickly, but we can give this to you as a resource just for training fellows, which is why we put it together in some detail. Neointimal hyperplasia is this sort of rubbery stuff that's collagen and smooth muscle cells. Neoatherosclerosis, which we see a lot, especially now that we're applying OCT so much to stent failure, is calcium that develops inside prior stents. And underexpansion is seen commonly, as we'll talk about, and that's when the stent is too small when it's put in the artery. And we know that the flow dynamics and problems with this lead to rapid acceleration of ISR. We've got examples of IVUS for neointimal hyperplasia, IVUS and OCT for neoatherosclerosis, and IVUS and OCT for stent underexpansion. We'll talk a little bit about these in more detail mechanistically. Intravascular imaging is requisite for treating ISR because, as I said, you can't tell from the angiogram if there's ISR tissue present, what the consistency of it is, whether the stent is well expanded or whether it's undersized, and whether or not there's stent fracture. And so with that, really the mechanisms of these multiple reasons for stents failing, you can't tell from the angiogram, lead to dramatic differences in your potential treatments. I would argue you can't treat stent failure well unless you know the underlying root cause, which is why we're so focused on intravascular imaging. Despite the fact that, we know that imaging matters for ISR based on this bit of data, is that imaging provides sustained reductions in MACE when treating ISR patients. If you use IVUS to guide your ISR intervention, patients do better. So effectively, when we use imaging, we see better outcomes. But unfortunately, in ISR patients, imaging is not routinely used. This is one of multiple studies which show for ISR lesions in general databases, only 20% of ISR cases are treated with intravascular imaging. So that's an opportunity to do better in the future. Because I've become known as sort of a stent failure guy, I sit on a lot of the abstract sessions and poster sessions for stent failure at our major meetings, and the highest number of ISR registry cases that have used intravascular imaging is only 35%. So I think that's an opportunity for improvement as we start to move the field forward for this large number of patients that need treatment every year. So thinking about ISR mechanisms and treatment challenges, this is just meant in some part to be a little bit of a guide to what the imaging looks like by IVUS and OCT for the 4 or 5 major entities of stent failure, with a nod to the fact that each of these different mechanisms has specific treatment challenges. So this is what neointimal tissue looks like by IVUS and by OCT. You can see the stent struts here, a little harder to see by IVUS, a lot easier to see by OCT. In this particular entity, this is non-calcified ISR. So as we think about this, You can find the stents, you can find the lumen, and you can find the neointimal volume and get some assessment of what the consistency is. There is some heterogeneity of what neointimal tissue looks like. I pulled those slides out of this deck to be brief. I'd be happy to share those too. Sometimes you can see a little bit of lipidic material in it, and a lot of times you'll see calcium, as we'll get to in a couple minutes here. And so as you think about neointimal tissue treatment challenges, a lot of things can be painful about this. This is at baseline. And as you know, a lot of times you put your small balloon up to focus pressure on treating ISR, and it tends to slip off. This is called watermelon seeding, when the balloon slips. And there are some good technologies which can help with this. We also tend to see tissue recoil, which is where you balloon this, it gets big, and it comes right back. The fellows may notice in their brachytherapy cases, and we've seen this for a long time, you do your final ballooning of your ISR in a brachy case, planning not to re-stent it. You're happy with your angiogram and your IVUS or your OCT that you do. Then you call your brachytherapy colleague. And by the time they get there from whatever busy stuff they're doing, it takes about 20 minutes to the point where you're actually putting the brachy catheter down. And then at the end of the case, you do a final angiogram, which is almost always, to me, disappointing because the stuff has already started to recoil at that point. So the best angiogram you're going to get in your brachy case is right before you call your brachytherapy colleague, unless you balloon at some point in the future. This is actually a focus of a paper in the 90s, which Roxana Moran published, which was called instant restenosis. They ballooned ISR, patient went away, came back with chest pain, they relooked, and the damn ISR, which looked good 2 hours before, had come back in large part. This is because of this annoying recoil problem. We don't have a good technology to treat. The other thing that happens with neointimal tissue that can dissect like this is the main reason why, if a patient is sent to me for brachytherapy, if they've got well-expanded stents with a lot of neointimal volume, and we balloon this and it dissects such that there's impingement of flow area, sometimes you need to tack this back up, despite the fact that you're trying not to re-stent these brachy patients. It's somewhat annoying to have to deal with this entity. So as we think about neointimal tissue challenges, it's really watermelon seeding and recoil. The tools we use to fight this are scoring and cutting balloons, laser atherectomy to some extent, because it's thought that it can debulk neointimal tissue, especially in large stents, though it doesn't really do a huge amount of debulking, but there is some potential mechanism to at least lessen the amount of tissue in the artery. And then non-compliant balloons, which obviously are just expanded well to try to get the stent and the neointimal tissue to get bigger, understanding that recoil can be a problem with this. Thinking about scoring and cutting balloons, these do have some advantages. This focal force pressure, for which many studies have looked at the finite element analysis of how these things work, do allow the edges of the balloon to lock in so it doesn't slip. And it probably does offer some advantage over getting better expansion for resistant lesions compared to regular balloons. Now, this is sort of a lot of benchtop stuff, some super small single arm studies, not a lot of fine data in this space, but there does seem to be some recognition, I think, agreement that there is a value proposition to these balloons in treating resistant lesions and in stent restenosis. This is what a scoring balloon looks like. When you treat ISR, you do see some divots where the wires on the balloons are able to actually help to break this stuff up a little bit. My sense here, and it's probably shown better on the next slide, which is the Wolverine slide, is when you cut this stuff, as you do with a cutting balloon, you allow it to be discontiguous. And it seems to be, at least in our experience, that tends to lessen the tendency of it to recoil a lot because you're able to keep the stuff, it may recoil in this dimension, but at least the radial strength of it is broken by the scoring or the cutting balloons. And so in big stents that have a lot of neointimal tissue, if we do laser them, we'll often try a Wolverine to see if we can kind of slice it a bit to help prevent the recoil. That's not based in data. That's based in experience, but we've been trying that because probably the most annoying ISR case is the one with a big stent with a lot of tissue that just keeps recoiling, and you don't want to put another stent in. You could potentially add a third layer. We hate to do that because of the onion skinning and the luminal crowding I'll get to in a minute, but recoil is annoying in this space. I'd almost rather have the stent be underexpanded because we've got better ways to deal with that, as we'll get to. Calcific neoatherosclerosis is incredibly painful. It's a relatively under-recognized problem, in large part because people don't image ISR enough, as we already went through, but also because people don't use OCT as much as they do IVUS, and it's harder to recognize on IVUS than it is with optical coherence tomography. So for our fellows, this is an IVUS image of calcific neoathero. The stent struts are here. You can see that there's calcium. And if you sort of your mind's eye went to where the stent should be, there's calcium inside the stent. It's much easier to see by OCT, which has the typical OCT signature of calcium. You've got a dropout of signal in the wall with well-defined borders, and the stent struts are clearly here. This entity is painful. You're constrained in a Coke bottle, and there's nowhere for this stuff to go. And so this is a case where we use lots of either ablative therapies, such as roto or orbital, or potentially shockwave to at least soften this stuff up and lessen the chances of recoil. This is a case, probably this and stent under expansion resistant to laser or IVL are the cases where you will use atherectomy inside stents to be able to debulk this. And we do see this a lot, especially in older DES, unfortunately. Daniel, you've been probably applying imaging to some of the stent failure cases there. Do you have any thoughts or comments on this painful and somewhat noxious entity?
No, you're right. I think it's you're constricted by the stent behind and the calcium on the surface. So anything you can do to break the calcium and remove the volume, I think it's the, we don't have data to compare, but I think would be the best strategy there.
Yeah, and we've been
So my mind, when we have these type of calcified neoatherosclerosis, is always some sort of ablative therapy as well to reduce the volume and try to get that bigger lumen.
Yeah, that's exactly what we try to do. And I've been trying to apply shockwave to it to see if it has any value. The recoil problem still seems to be present, although it can make it better. It tends to make it better when it's this problem and there's underexpansion. I think probably because the fracture of the calcium is happening outside and inside the stent, and you're making the underexpanded stent bigger. So mechanistically, I can't say I understand it, but it's been painful enough. We've been sort of trying some off-the-wall ways to deal with it. And so, calcific neoatherosclerosis, as we talked about, poor compliance and inability to expand and recoil are the main issues. And this is where we start to ascend the concept of the tools which are available to deal with this. And so the concept, and we'll get to this more deliberately in the algorithmic part of how you treat stent failure, but you're ascending an aggressive curve here from just simple NC balloons to scoring cutting balloons to OPN to IVL to laser rodent orbital. And as you go from simple balloons toward drilling out stuff inside stents, your aggressiveness goes up, as does the potential for complications. And so we tend to apply these in somewhat of a stepwise fashion. Try scoring balloon, try OPN now that we have that, try IVL. And when that doesn't work, you can move forward with rodent orbital, understanding that's because you failed on the earlier, more gentle and safer things that you tried up front. And we'll go through that in detail in the algorithmic portion. Underexpansion is somewhat painful also, especially when the stents are constrained in calcium. Here's a little cartoon that shows what it looked like. This is an IVUS image of the proximal and distal segment of the stent with a stent that's grossly undersized and underexpanded. The calcium signature in this case is not very bad. I wish this is all that they look like. A lot of times when we inherit these for multi-layer stent failure patients, they're socked in both extra and less often intra-stent calcium. This is what underexpansion looks like by OCT. OCT makes it easy because you get this beautiful longitudinal view. Simply, you can tell what the area is distal and proximal. And the nice part about it is because OCT can see calcium well, you'll very frequently see the calcium behind the stent struts and get a sense of how thick it is. We use the imaging a lot in these cases, especially with OCT, because if you see a millimeter of calcium behind the stent and the stent is underexpanded, we know from experience right away that's not a balloon angioplasty problem. That's going to take either IVL, laser on contrast, or rotational atherectomy to be able to address it. So it does help with case efficiency, because understanding what you're treating allows you to get into that stepwise progression of treatment a lot faster, because you have a sense of what will and what will not work based on experience. And good expansion is very simply defined as, is the stent holding the artery open to a similar extent to the reference segment distal and proximal? This is the hallmark of MLD max, with M being medial dissection. We want to make sure we don't have those. A being apposition. Look at that. Try not to leave stents grossly underposed, although it's not as important as the last thing, which is X for expansion. And so our goal is to get every stent we place at least 80% expanded, but preferably 90% expanded. And you're lucky enough as fellows to have Daniel there, who can teach you in a couple of days how to do this in a very quick and deliberate way. And I imagine you're all experts at it. But we will look at all of our ISR cases, and you should do this too, and just simply draw a line where the stent struts are in the MSA and you can quickly calculate the percent expansion relative to the distal and proximal reference segments. Are you guys doing that now for your ISR cases, Daniel? I imagine you are.
Well, we do that on a quick assessment, but I personally prefer the tapered mode, where you can actually assess the expansion on every single cross-section along the entire stent, as opposed to just looking at the MSA and comparing to the reference. So we look at both. This is a quicker way of doing it, but I like the tapered mode best than that.
Yeah, in our lab, that's what we've graduated to also. So all of our OCTs are tapered versus dual reference, exactly. And then the nice part about that is, sometimes the computer will often plot the lumen area, but we'll often draw a line actually on the stent struts to understand where the stent itself was relative to a proximal and distal segment. And that mechanism is how we've generated some of the data on stent failure. We may have a chance to talk about in a little bit if there's enough time. So as we think about, stent expansion, we want to look to see whether it was or was not well expanded as the cause. And this is just an example of how bad the angiogram can be at telling you a problem. This is the patient who was referred to me for acute stent regret. The angiogram looks like it's probably maybe a 30% residual stenosis. When we actually did stent boost here and magged up on it, the stent hardly expanded at all. And when you actually go ahead and do the OCT, you can see there's a minimal stent diameter of 1 millimeter, which is socked into a millimeter of calcium. So this took about 10 runs of laser on contrast to cause fracture to be able to get it to open. And eventually we popped it open and was able to address this. And so I think it's just a nice example of how bad the angiogram is at showing you what's going on in a case like this. So the under-expansion tools mirror very much the tools for calcific neoathero, NC balloons, scoring cutting balloons, up toward IVL, laser on contrast, rodent orbital. So it's really the same tool set, and we apply them in a progressive fashion. IVL very nicely is able to fracture calcium in constrained and underexpanded stents. Example of that here. There is data on this. We tended to loop IVL and laser into the same bucket because they effectively, for calcium, do the same things. They create shock waves. We have some recent data we're looking to publish this quarter that we put together with Philips, that laser on contrast gives you a very similar shockwave effect to IVL. You get about 60 atmospheres with a 0.9 laser on 50% contrast. And so the acoustic or optic kinetic energy is just a fancy icon to say laser and shockwave are similar in their mechanism of action if you're using laser on contrast. Full disclosure, laser on contrast is off-label, although I know lots of people there are using it regularly as we are. So thinking about laser and IVL for underexpanded stents, there's a good and clear understanding that the shockwave effect is able to fracture calcium intrastent and extrastent, which allows you to help it to get the stent expand well. This is data from Evan Schlafmitz. It just looks at the increase in ISR, minimal stent area, with and without fracture following IVL. When the IVL is able to fracture the calcium, you get much, much bigger lumens in your ISR tissue, your ISR lesion. And so I think our goal, just like every calcium modification, ISR is no different. Use some therapy that helps to fracture the calcium to be able to get your expansion better in an underexpanded stent area. And so laser does the same thing. This is contrast augmented laser. This is the exact images from that acute stent regret case I showed you a couple minutes ago. The minimal stent diameter is 1, 9 runs of laser on contrast, a high pressure angioscope, we're able to cause the fractures, which are commensurate with getting good expansion here. And so thinking about laser for underexpansion, we know that laser debulks tissue. Its ability to do that in ISR tissue is moderate at best. It doesn't remove as much tissue as we would like, but it can work. And then the acoustic mechanical energy of 60 atmospheres works a lot like shockwave. The difference is in terms of which you use. Shockwave is nice because it causes less no reflow than laser on contrast, but you're pulse constrained. And so if it's a long segment or you have to do a lot of treatment, we'll tend to use laser. If it's a little artery without a lot of outflow, where no reflow is more likely to be a problem, then we'll use shockwave. But they really are kind of in the same toolbox for us in terms of how we apply them to these cases. We also know that laser atherectomy, much like the data I showed before for shockwave, is able to augment lumen area. This is an older study from Roxanne and Moran in 1997. I bet a lot of our fellows are probably either in nursery school or maybe not even born then. But laser with balloon versus balloon only gives you bigger lumens if you treat in-stent restenosis. And this is in large part probably because of some debulking and some change in tissue consistency to allow the stents to expand better. Were you practicing in 1997, Mike?
Yes. Nice, 1982.
Awesome, amazing. Well, a lot of the stuff we've learned is on the shoulders of you guys that have been doing this a lot longer, so we appreciate that. This is just a quick high-speed video of what happens when you laser on contrast. And you can see here, this is what the reverberation of the shock waves look like from lasering on contrast. And so this is what we're trying to harness in these cases. If you don't do this right, you can get pretty bad no reflow. So the technique here matters. And this just shows laser on contrast in terms of how much cavitation you get when the laser light interacts with the rings in the contrast media. And so with this is a study from your intervention that just shows if you laser on saline versus lasering on contrast, you get much bigger fractures in the calcium. So the augmentation of the acoustic mechanical energy allows the laser to be able to work effectively. So again, shown laser on contrast augments the energy. And if you laser ISR, you get much bigger lumens. And so we're able to use these tools, shockwave and IVL, to deal with underexpanded stent in a pretty deliberate way. And so when laser and shockwave and OPN don't work, we ascend to the more complicated parts of these cases. We've gotten very facile with drilling out underexpanded stents with rota and orbital. Orbital is contraindicated by labeling for in-stent restenosis. That said, there's a bunch of case studies and we use it somewhat regularly, although it does have probably a less favorable safety profile for ISR than rota does. You can get them trapped more and they can kind of be a pain. And so the main risk of rota and orbital really is burr entrapment or major dissections peri-stent. And we know these two devices have different mechanisms of action. If it's a large artery, we tend to favor orbital because the 360-degree orbit that the device makes allows it to contact the wall better than rotational, which is dependent on wire bias. These are a couple of my cases. This is multi-layer underexpanded ISR treated with rota. You can see beautifully the wire bias. We've cored out half of the stent along the place where there's wire bias, and you can see the rota made a little divot in the intimin media here. Contrast that to my orbital case, where we're actually able to ablate the stent in the entire circumference. And much as we do in practice, smaller stents get rota, larger stents get orbital. So this is an orbital treated artery, and there's only a couple stent layers left. And so, you know, I would be mindful that this is a case you want to be doing with someone that has a little bit of experience if you're going to start doing this, because the rota burr can get stuck. To mitigate the chances of rota burr entrapment, we tend to go about 190 to 200,000 RPMs to lessen that, because we know at higher RPMs, rota burrs getting stuck is less common.
Can you talk a little bit about choosing burr size in these cases?
Yeah, so if it's a 2.5 artery, with some reluctance, I will consider a 1.25 burr because it's a small artery and I don't want to have major decels. That said, as you guys know, the 1.25 burr is the one that's most likely to get stuck because of its shape. So my favorite burr to start with is a 1.5 at 200,000 RPMs. And you have to be really deliberate. You touch the stent and back it up. If you touch it and push it hard and it pops through early, that's when you get these things stuck. And there's a really nice algorithm, which I'm sure Yusuf and your other CTO colleagues are very facile with in terms of how to get a stuck rota burr out. For CTO Plus this year, they asked us to make a bunch of little training videos. And I made one on like a benchtop model of how to unstuck a rota burr, which if you guys want to have that, shoot me a note later. I'll just send you a Dropbox link to it, just in terms of understanding when you get a burr stuck, how to get it out. There's a bunch of cool tricks for that. And so the times I've gotten burrs stuck have almost always been in ISR cases like this, which is a somewhat terrifying complication that we'd like to avoid. And then I will go from a 1.5 to a 1.75 burr pretty regularly, again, using both at relatively high speeds, with a reluctance to use the 1.25, except in really small arteries.
And in orbital, do you, for the speed setting, do you start on low, and then if it's a big vessel, occasionally do some high speed runs?
I do, and I tend to try not to transit the burr very much. You just sort of park it in the hourglass and let it work there. You don't move it back and forth a lot. I've caused some really bad intra-stent dissections with orbital, including the last one we did, we actually mangled the stent so much that every balloon that went back in ruptured until I tried an angioscope, which actually didn't. But it's my least favorable thing to use, but sometimes we have to. Our need to use orbital in stent, which is typically applied to larger arteries because of the mechanism I mentioned, has been really obsolesced a little bit by the fact that we have shockwave now, which I tend to go to first because I think it has a better safety profile in these cases. Other questions on that, Yusuf?
The only other one I wanted to ask you was, you commented about technique for laser on contrast to try and reduce the chances of no reflow.
Yeah.
Could you just expand for us a little bit?
Yep. So we should get this paper out relatively soon, but we've been able to show through some work with the Philips engineers the maximal acoustic mechanical energy augmentation with laser happens at 50% contrast, and you don't get any more increase in the acoustic mechanical energy after that. So the way we do laser on contrast is very clear. We have 100% contrast in the syringe, and we inject 0.3 to 0.5 milliliters every second that we're lasering. So if you're lasering for 10 seconds to 0.9, if my fellow's at the back of the table, or more likely I'm in second operator position, I'll puff about 1/3 of a cc to 1/2 a cc every second while lasering. So it's puff, puff, puff. And if you're getting angry because 4 or 5 runs in, your balloons still aren't releasing, then you can give a little bit of a larger bolus, 0.5 to 0.75 cc's. As you get to that level of 100% contrast in the syringe, probably 50% delivered to the tip of the laser as it admixes with blood, that's typically when you start to ascend the risk of no reflow. And we may not have time to go through it, but we have a little paper that we're trying to get out on 350 sequential laser ISR cases where 50% of them use contrast, and we only had about 3% no reflow. So if you do it in the way I described, it's relatively safe, and it's also pretty effective at getting stents to expand when they're underexpanded.
That's very helpful.
Again, this is all off label, so it's kind of hard to teach in a lot of usual educational sessions. The pain we're working, a lot of reason we're doing this research on laser and contrast is so Philips can get it on label, so we can actually train people how to do it, because this is a pretty helpful tool. There's stent fracture comes in different types. I won't belabor this. It's kind of like the Mehran classification of ISR. I don't know if it has a whole lot of clinical utility, except to say that they fracture in different ways. Stent fracture is annoying. A lot of times there's not much you can do. There is a healthy conversation about whether you take thin struts or thick strut stents to treat stent fracture. People who are experts in terms of stent mechanical structure tell me stiff stent is not always a good choice to restent stent fracture. And so, maybe not a Megatron, maybe more toward a Synergy or an Onyx is sort of what I've been coached to do. But I don't have personal knowledge of sort of the finite element analysis that allows people to make that statement. I just trust that they're smarter in this stuff than I am. Stent fracture, when I've seen it most commonly, occurs sometimes acutely, which is super annoying on calcific nodules. But as you start to image more as a program, we've seen that a lot of our stent fractures occur on nodular calcium. And I'm sure Daniel can probably attest to that based on his experience. And so this is an example of what it looks like by OCT for the fellows. You can see there's a stent probably about 2/3 of the way around the circle, and it's not present here, which means it's fractured across some distance. And the OCT longitudinal view is often helpful because the computer is pretty good at picking up the stent struts, and you can't see them in this segment. And so ISR treatment of fracture is similar. You got to know the sizing. You got to know if there's calcium there. Mechanical stress is something to consider, although there's not a lot we can do about that. And then we have to consider restenting in these cases, unless you get a good balloon result and can deliver a DCB or do brachy. Really understanding your balloon result is the consideration before deciding to restent these things. But especially in acute cases, I think restenting is necessary. One thing to note, if I do get acute stent fracture on a nodule, and it's not a bend or hinge point, I will then take a Megatron just because of the stronger stent struts and thicker struts. I do believe there's some value to you, but these are somewhat painful entities to deal with. And so, multi-layer ISR is a pain. This is what it looks like by OCT. You can see there's a lot of thickness of strut here. It's harder to count, by IVUS. It's harder to count layers by IVUS. One of the nice things about OCT, and this is one of my cases, you can actually see the number of layers. And the reason we don't like to put a 3rd and 4th layer in is you get the sandwich of stent upon tissue upon stent, and you get horrific luminal crowding, which becomes miserable and impossible to expand as you go down the road of sort of getting more and more layers. The largest number of layers we've seen in our program is 5 layers, which is relatively painful. I'm going to go through this relatively quickly, but the value proposition for OCT for ISR is it's low profile. You get your best resolution of luminal assessment and things like calcific neoathero. You can see multiple layers. And the bad is you can't really see the MSA because outside the stent, it can't see well deep into the artery. So your sizing is always based on reference segments. You often can't see the media to assess prior stent sizing. IVUS is good because you can see the media outside the stents often. It doesn't require contrast, but it's hard to tell the number of layers. And at least for me, it's hard to see calcific neoathero as clear as you can by OCT. So I'm going to skip over this. This is just kind of a case where we looked at an angio, decided what to do with decided what to do, and then compared our OCT data and changed a lot what we did. This is a light lab case. And suffice to say that I chose a different stent. I chose a different prep strategy because there was calcific neoathero, and we got a good result. I'm going to move forward to get into the algorithm piece because I think it's helpful. Yeah, there's a question? Was there a question?
So Kevin, you mentioned about the calcific neoatherosclerosis, which is clear why it's an annoying problem, but there is also another entity, which is the lipidic neoatherosclerosis, which is sometimes very easy to expand. But when you see lipid inside a stent, this changes your management somehow, or you just don't care, you stent it across and
yeah, so, if it's single layer and we're going to put another stent in, I don't worry too much about it. We will see it by OCT, as you allude to. That's sort of the case gallery of the different types of neointimal tissue I took out. So I made it very bimodal. It's either firm or hard, but there are nuances, and you'll see very nice lipidic deposition in it. I don't understand the meaning of it for treatment. They tend to recoil, in my experience, a little less than firm ISR neointimal tissue, but I don't have a lot of clarity in terms of what I do differently. A lot of times, if it's multi-layer, we're trying to balloon it to brachy it, or someday balloon it to DCB it, but I don't have a lot of insight in terms of its ramifications for retreatment or et cetera. Do you have any thoughts on that?
No, there is a lot of inflammation together when you see these large lipid pools. So as we're about to get DCBs for in-stent stenosis, I always wonder what would be our best strategy to be minimalist in terms of adding layers, and at the same time be effective in the treatment of these very active and inflamed plaques.
Yeah, I think DCB may be really nice for that. Also, is brachy a good choice for it because it's going to be a pretty strong hammer to reduce inflammation. I don't think we know, but as we do more OCT imaging, we see a lot of that in these cases, as you point out. So.
Yeah. Kevin, can I ask you one thing it's a little bit off the track here?
Yeah.
But you had mentioned, nodular calcification.
Yes.
What's your, there was one single center paper that looked at, that stated that shockwave and roto could fracture nodular deposits, which hasn't been my personal experience.
Yeah.
But,
so
what is your approach to that?
It's a great question. It's one of the more painful entities we have. So the single arm look back at Disrupt CAD3 that Akiko Mera presented about 6 months ago, had sort of stratification of nodular calcium treated by shockwave in the setting of dealing with sort of more standard circumferential calcium. She showed the following. About a third of stents are perfect circles, a third look like a D, and a third look terrible. The safety profile and TLF of shockwave treated nodules looked better historically compared to studies of ROTA for nodules. So that's the best we can say, is that the stents look okay 2/3 of the time. And it seems like shockwave may be doing a little better in a non-randomized, not head-to-head look. So I've been with that applying shockwave to nodular with some frequency. And I'm super deliberate about whether my $5,000 choice of therapy works well. So I OCT every one of these on the back end to try and inform our practice. And it seems to work often, but not as reproducibly as I'd like. And so it's better than nothing, certainly. In large arteries, it's probably better than ROTA, because with ROTA, you're dependent on wire bias. And the place this always happens is on the inner curvature of the osteal circumflex. which is my belief why we see so much ISR there. And a lot of time the rotor rides away from that. And so in those cases, I've been applying either as an IVL or an orbital problem, especially in large arteries. And we seem to do okay with it. I've had lots of cases where the IVL has a divot in it. In over 80 pulses, it gets better in the IVL balloon. And there are some nice micro CT studies which show that IVL is able to fracture the base of the nodule, which rota and orbital probably don't touch. And so we need more data on that because it's a painful common entity. We're realizing it's a lot more often encountered now that we're imaging more, but we don't have a great algorithm in terms of what to do. So by way of summary, for me, it's typically an IVL and an orbital problem more than a roto, unless the roto wire bias is gonna touch it based on what I can tell and where it is. Is that helpful?
Yes.
Great. All right, so I'm going to get to the algorithm piece, which is kind of fun, and we'll probably wrap it up after that. So we worked a lot to put this together. We're going to come back to our tree with the idea that, unhappy heart, not getting good nutrients. There's a cause for why the stent failed. It's a root cause analysis that needs to happen around calcium, fracture, neoanimal tissue. And we really have a stepwise therapy that we're going to go through in terms of balloons, acoustic mechanical energy, ablative energy, high pressure with OPN, with the idea that our goal is then, after we get the stent to expand, to be able to use DCBs, brachy, or in worst case, a new stent to apply some anti-proliferative treatment. This is the general constraints. And the case really gets broken into two parts. Assess the root cause diagnostically, move forward with stepwise therapy to get 80 or 90% expansion of the failed stent in the middle here, and then treat it with some anti-inflammatory process to keep the darn ISR from coming back. And so assess the root cause. We've pretty much got simple question. Is the stent underexpanded or undersized? Is it fractured? And is there ISR tissue present? If there is any of these entities, you need to know if there's calcium there. And if there's a lot of calcium, you're going to ascend up the complication-ridden escalation of from balloon to laser to IVL to drilling it out with the goal of getting your stent big. After your stent is the right size, greater than 80% expanded, shown by imaging, not by the angiogram. This is an IVUS or an OCT decision. Once you've gotten the stent expanded and you're sure of that, then you need to think about, am I going to re-stent? Hope not to. Use a DCB, hope someday to, or use brachytherapy, as I know you guys have access to. So we'll go through this in a little bit more detail. So first question is expanded and or well-sized. If the answer is no, you also want to know if there's ISR tissue present and if there's calcification either in it or outside of it. If it's underexpanded and there's no calcium, it's pretty much a balloon question, like that IVUS image I showed you. If it's undersized and or underexpanded with calcium, you're going to be thinking about something that's either shock waving, laser or IVL, or drilling, orbital and roto. If there is ISR tissue present, as we talked about, you need to know if it's soft or lipidic tissue, or if it's calcified neoatherosclerosis. The latter of which, calcium, also will send you along the laser, IVL, roto orbital chain to be able to get the stent to expand well. So as we think more about this then, the idea here is you are ascending for neoanimal tissue, as we talked about, scoring balloons, cutting balloons, maybe laser to core some of it out. If it's calcific neoathero, NC balloons, scoring, cutting balloons, hopefully. We've used probably OPN 10 times in the past month since we've gotten it for underexpanded ISR. It's been amazing. 44 atmospheres does make a difference for multi-layer ISR. Not what I haven't perforated yet, but if we start using this tool in the way we've been in the past month, I think it's going to happen eventually. And then IVL, laser, roto, orbital. Again, you're getting to the place where things can happen in these cases, which are unpleasant because drilling out stent struts has a finite and real complication risk. If it's undersized, but there's no calcium, it's just a balloon problem. And if it's undersized with calcium, again, you're going to escalate to acoustic or optical energy to fracture the calcium and rodent orbital. And our goal is to get to 90% expanded if possible. Once you've got the stent expanded, job number one is done. Now you need to mitigate the inflammation that you have that's going to make the ISR come back. And this is where we've got this inflammatory treatment. The next question is how many stent layers are present? If it's multi-layered, we'd like to use a D someday here or brachytherapy. Because of that onion skinning I went through, the goal is not to pack the lumen with metal. If it's single layered, you have a little more latitude. It's probably more reasonable to re-stent in that case, or you can use brachytherapy if, like you guys, we have the latitude to do that. Times when we put a new stent in are intra-stent dissections of neointimal tissue with a large impingement of the flow area of 40% or more. I showed you an example of that. Unfortunately, at the time, they have to call back referring and say, I know you sent the patient with 2 layers for brachytherapy, so you don't have to put a new stent in. I had to put a new stent in because the OCT showed I had just a pile of neointima that had dissected in the lumen. This tends to happen more with laser on contrast because you set a bomb off in the artery. I've seen the neointima peel away from the inner layer of the stent. And so that's cases where we have to re-stent. The imaging allows you to know that. The angiogram doesn't. And in cases where there's stent fracture, unfortunately, we often have to re-stent there just because there's often dissection and bad neointimal recoil with it. And we try to avoid that, but sometimes you have to. And again, the goal is someday to have DCBs because you won't leave any metal behind. But in the current era, we're always deciding between brachytherapy or re-stenting. So, ensuring the prospective patency of a well-expanded stent, the goal is to treat the inflammation, DCB or brachy. If scaffolding is needed, we only consider a new DES to augment the MSA. And with that, you get drug that comes along with the polymer that also treats the inflammation. We're a little more liberal with breaking fresh stents that we place. A lot of places are reluctant to do that because there is a potential risk for stent thrombosis. I have a few cases of examples we won't have time to go through. So I'm just going to kind of go through a little bit of summary here real quick, and we'll leave 5 or 10 minutes for discussion. So by way of summary, assess the root cause, get the stent big with all the tools we reviewed, make sure it's well expanded, and then do something to prevent inflammation, which is going to cause the stent fail again. So this is the way we've kind of broken it up into a workflow, which allows us to understand, why the stent's failing, get it big, and hopefully keep it open. I'll just share with you one more bit of evidence. And so when you apply this stepwise progression to multi-layer ISR patients, this is using our stent failure algorithm. We see that more than 70% of multi-layer ISR patients sent to us for brachy have underexpansion. I've shown you that data before in terms of imaging talks we've gone through. But if you take that population of patients that are hard to expand, balloon unexpandable, and you apply this algorithm, you make a lot of them have much bigger stents. But this is sometimes miserable work. Despite spending, $5,000 on devices, some number of the patients actually can never get expanded well. That's why the first stent has to go in perfectly. So again, I really appreciate the opportunity to be here today. You got a lot of good friends and colleagues, and it's an honor to be able to share some of our new work on this with you.
That was terrific. Thank you very much, Kevin.
I think it really speaks. I have to run, Kevin, but it really speaks to your point about IVUSing for your initial stenting procedure. Because if you do it the right way at the beginning, you really reduce your ISR considerably, and you make your headaches much less. And
yeah,
I think that's where you get into trouble.
I agree, Mike. And my grandmother, who died at 96 years old, used to tell me an ounce of prevention is worth a pound of cure.
Yeah,
$800 on an IVUS catheter and an MLD max case versus, $9,000 on an IVL, a road, a stuck burn, a dissection. I completely agree with you. Get it right the first time.
see you, Kevin.
Take care, buddy. Really nice to see you.
So, please, anyone from the chat, let us know if you have questions. My question or comment is, it seems when you present that, that algorithmic approach, even if your root cause of the ISR is a mechanical issue, you're always trying to apply some anti-proliferative therapy at the end. By which I mean, so if you get a case referred to you for brachy and you image it and you discover a mechanical issue, you work to resolve the mechanical issue, but you still strongly consider finishing off with brachytherapy?
Yeah, we always do. And the reason why, Yusuf, is as we've got, we have a lot of friends regionally that send us these cases. And we talk a lot about it in like New England CAF conferences. We share what we did. So a lot of people who are really good interventionalists have gotten super competent on addressing the underexpansion, but they don't have access to brachy or DCB. And I've found in a select number of cases, they take a 3.5 artery that has a 2.5 underexpanded stent, They use laser, IVL, rota, whatever it takes to get it to expand well. And they say, all right, I've addressed the underexpansion. Let's see how the patient does. And that seems reasonable, right? And I don't have the N in terms of the number of patients that do well. But the ones that come back to us then have a really big stent that's multi-layer with a pile of neoenema in it because the inflammation wasn't addressed. And at least for me, that's the hardest problem to deal with. We don't have a good technology because then you're trying to smush this stuff, it recoils, you laser it, it dissects, and you end up putting a third stent in. At least in those cases, it's a big artery. And what we long for is something to reduce the neoenema burden because the MSA of the lumen in big neoathero arteries that have a lot of neoenema tissue is never great. And so we just submitted an NIH SBIR 2 months ago for a new device that we developed that is a ISR atherectomy that's going to core some of this stuff out. The grant got a 50, so it's going to need to be revised, but we're at least in the ballpark because I think it's enough of a need to be able to kind of get big lumens, which could help in this space that we maybe will have an opportunity to think about, all right, let's debulk a different way because laser doesn't do as much as we'd like it to. It'd be cool, Daniels, you guys do some laser cases. If you have OCTs pre and post, it'd be fun just to collaborate in terms of, neoenema volume, ISR before laser, neoenema volume, ISR after laser before ballooning. It doesn't seem to core out as much as I'd like it to. It is a case, though, where I will use a bigger fiber because the ablative size of the laser goes up as you increase the fiber size. But I don't have a great technology for that. So we always like to use some anti-proliferative effect because in the number of cases that come back, you then get a different, and I would argue, worse problem.
That's very helpful for me. That's potentially, practice changing because I think my protocol internal algorithm has been what you described a lot of your referrings doing, that if I identify a mechanical problem, I'll try and solve the mechanical problem as best I can, and then see how the patient does and keep brachytherapy in the back pocket, so to speak. But the way you describe it, they come back with, a different, potentially worse disease process. It might make sense to, set these patients up to radiate them at the end of whatever we've done.
Yeah, and we get a lot of people who are sent to us having been ballooned for stabilization 4 to 8 weeks prior. Like, non-STEMI shows up in New Hampshire. Most of the docs we work a lot with are like, hey, Kevin, I just ballooned this lady to get rid of her chest pain. We're sending her home. Can you collect her in the next 6 weeks for brachy? We do that routinely. That probably accounts for half our brachy volume now. And I didn't go through in too much detail, but the multi-layer ISR patients that get ballooned, almost half of them seem to come back based on the published literature. So, I don't know the right thing to do, to be honest. Should be 50-50 chance at best that they're going to do okay for the next couple of years versus they come back with a worse problem. We've taken a pretty heavy-handed approach to getting them radiated in a second procedure. I don't know that that's the right way firmly, but based on the problems we have when they come back, if the stent is well expanded, we've gone to, anti-proliferative therapy. And a lot of our referring docs, unlike you guys, don't have the skill set and all the tools to deal with the mechanical problem. Like, you're obviously doing it well. You're imaging, you're busting the stent open, you're dealing with the main reason it failed. Most of the people that refer to us from smaller centers that are a little less technically savvy with this algorithmic approach, you're just like, we just ballooned it to make the chest pain and non-STEMI go away. You can deal with the laser, the rota, the IVL, and all the imaging stuff when they come to you. But you're in a different situation because, even personally, if I see an ISR patient I want to get brachyed, I'll just probably pop it open with a quick balloon and I'll run the whole gamut when they come back for their brachy 6 weeks later. It also allows you, it's like a CTO, right? These aren't easy cases. They're somewhat painful oftentimes. So, you got 3 hours blocked off. You got a lot more time for it. It's not like this is like the 5 o'clock special, right? The lady with 2 layers in her RCA who shows up as a non-STEMI as a late add-on. We tend to like to do them just in a way more deliberate, we're going to take our time way.
Yeah, that makes a lot of sense. I think we have time just for one question from the chat from Yassine, one of our fellows, who's asked, is there any way to predict which ISR lesions will recoil? So after you modify the lesion, you have a reasonable MSA. Do you feel comfortable stenting if needed? And which ones do you worry about recoil affecting the MSA?
Yeah, it's a great question. So, Large arteries with a small lumen and a thick tissue are the ones that almost always misbehave. Made worse by the fact that large arteries with a small lumen from the fact there's a rind of neointimal tissue with calcific neoathero, those are the ones that even misbehave more. And I'm sure Daniel's probably seen that. And so it's a combination of how big the artery and how much the thick stripe of neointimal tissue is. If you get it big, it will often come back, especially if there is a lot of tissue there that can squash and then recoil. It's really an annoyance, which is why we're trying to develop a device to deal with this. We'll see if we can get the NIH to bite on it. It's a great question. So thick rind and neointima and or with calcium are the ones I worry about. And those are also the ones that dissect and may need restenting.
Brilliant. All right, thank you so much, Kevin. That was phenomenal talk, great discussion, really valuable for us. So thank you for your time.
Yeah, I appreciate it. If you guys want, if there's a fellows conference, we could it'd be fun to get your fellows and my fellows together. I've got probably 5 or 6 cases that go through the algorithmic application just on a case basis. So if there's like a Monday or Tuesday at 6:30 or 7, you guys do it, I'd be happy to just come back and kind of walk through how you use this in some case examples we didn't have time to get to today.
Yeah, that would be great. Yeah, let's try and set something up with more case sharing, and that would be all. I'll email you.
Awesome. Great. Nice to see everybody. Have a great day. Appreciate the invite very much.
Thank you. Bye.
Be well. Take care.